Okay, everyone, we're going to get started. Welcome to session 11 of the Washington Healthcare Facilities Initiative webinar series. My name is Joanne McGriff, and I am the Associate Director of the Center for Global Safe Water, Sanitation, and Hygiene at Emory University, also known as the CGSW. And I'm also an Assistant Research Professor in the Department of Global Health at the Rollins School of Public Health. I am joined today by members of our learning team, Ms. Lindsay Denny and Cassandra Savino. If you have been with us over the past several months, or maybe even the past year, you know that our goal has been to connect, share, and promote action among the Washington Healthcare Facility community of practice. Well, as we approach August 2019, we'll be coming to an end of the 12-month monthly webinar initiative. We will hold our final webinar in August 2019. After this, we won't hold it on a monthly basis, but the initiative itself will continue, but in a different form. Starting in September, we will have periodic webinars covering special topics that are important for the continued improvement of the Washington Healthcare Facility community. These topics will come from the community of practice, it'll come from technical experts, and any other individual institution that are working on the ground in Washington Healthcare Facilities. We will also use our current listserv to send updates, announcements, and select resources that will assist the more than 600 members of the list so that all of us can continue our work. We will continue to post all of our resources on our website at wnhcfaction.org, and we continue to welcome feedback and comments at our email address, wnhcfaction@emory.edu. And we will still hold on to our Twitter, which is found at WNHCFaction. So for today, I am pleased to have speakers from Engineers Without Borders and Splash International who will share with us the engineering perspective. But before we get started, I'll pass it on to Lindsay Denny for other updates and announcements. Lindsay?
Good morning, good afternoon all. Thank you for joining us for this webinar. Before we begin, I want to go through a couple of the guiding principles that we use to select both the topics and the speakers for this webinar series. So first, WASH is a fundamental prerequisite for quality of care within a healthcare facility. Secondly, we believe that there cannot be effective infection prevention and control without adequate WASH in healthcare facilities. Thirdly, sustainability should be built into every project for Washington healthcare facilities from the very beginning, no matter the project size. And I'm sure we'll hear about more of that later. And finally, Washington healthcare facilities is not just about addressing issues at individual facilities. Multiple systems, sectors, and stakeholders must work together to see sustainable improvements. For those of you who are just joining us, a bit of background. The purpose behind focusing so much on Washington healthcare facilities lies really in SDG 3 and SDG 6. In order to achieve health and well-being, goal number 3 in water and sanitation, we must address the issues behind Washington healthcare facilities in order for there to be water, sanitation for all, and good health and well-being. Secondly, in 2018, the UN Secretary General Antonio Guterres used the launch of the Water Action Decade in March to make a call to action for Washington healthcare facilities, which he reiterated last month at the stakeholders meeting for Washington healthcare facilities in DC. We've held 10 webinar sessions to date, covering topics such as health system strengthening, assessments, interventions, research, costing, national action, and global action as well. A bit of news and updates. There are a couple of updates on our end. First, in September, the WHO and UNICEF are hosting a 3-day meeting in Zambia for countries looking at the 8 practical steps for improving Washington healthcare facilities and how they can integrate this into their work. There'll be more information to come about how to follow along and participate from afar. Secondly, in research, an article was published earlier this month in BMJ Global Health that focuses on Washington healthcare facilities and healthcare associated infections. And I can put the link to that article in the chat box. So for this morning, a bit about Zoom. Feel free to use the chat box at any time to introduce yourselves, ask questions, or make comments during the presentation and the active discussion. If you could please select all panelists and attendees, that will allow everyone in the room to see your question or comment. And then during the discussion section, Please feel free to raise your hand to show the panelists that you'd like to ask a question with your microphone. Please only do this if you have audio capabilities on your computer or mobile phone. And you need to keep your hand up until we've reached out to you so that we know that you'd like to speak. And Joanne, I'll hand it back to you.
Great. Thank you so much, Lindsay. Again, welcome everyone to session 11, entitled An Engineer's Perspective on WASH in Healthcare Facilities. We are so very happy to have with us Michael Paddock, who's the Chief Engineer for Engineers Without Borders USA. He's a professional engineer and professional land surveyor with over 30 years of experience and has worked to deliver development projects in 5 continents. Engineers Without Borders is an organization that builds a better world through engineering projects that empower communities to meet their basic human needs and equip leaders to solve the world's pressing challenges. Mike's presentation will be followed by a commentary by Kith Rathamony, or also known as Moni, who is a regional liaison for Splash International on a water program in Cambodia and Vietnam. Moni graduated with a master's degree in public policy and is currently a PhD candidate in public administration program. He's been working in government for 5 years and has worked for various NGOs in gender promotion programs, children education and integration programs, hygiene programs, drinking water programs in public schools, hospitals, and communities. Again, we thank both of our speakers for being here, and I will hand it over to Mike.
Great. I will share my screen here. Hopefully you can all hear me and see the screen.
Yes, thank you so much.
Great. Well, thank you so much for allowing me to participate in today's webinar. You know, I've always enjoyed these webinars, and I'm glad to hear that they're going to continue into next year. And I've really found them very informative, and I really hope today's is equally helpful to you. Just a little bit more about Engineers Without Borders, because you may not be that familiar with us. We are a nonprofit organization with 17,000 energetic members who are working to build a better world through engineering projects. We currently have 684 projects in 40 countries and maintain 4 country offices, 1 each in Denver, Guatemala, Nicaragua, and Uganda. We have several programs, but the one that is most applicable today is the one called our Engineering Service Corps. It deploys our most experienced members. So these are members with lots of gray hair like myself, who have worked in developing world projects and provides services to United Nations, governments, other nonprofits such as Doctors Without Borders and Partners in Health. And we have found that healthcare facilities are excellent partners for us to work with. Healthcare professionals are doing amazing work around the globe and are dedicated to their work. And when we can help them by solving an infrastructure problem, allowing them to do their work even better, our members find that incredibly rewarding. Today, I'd like to talk about 3 main areas. One is sustainability. The other is ownership of waste. And finally, some observations about assessments. First, I'd like to just remind all of us that WASH is not free. I think I'm going to make a t-shirt and wear that message every day because it is something that is so frequently forgotten. Sustainability is so very critical to the success of our projects and must be addressed before a shovel is put into the ground. Engineers are trained to look at a system's life cycle cost. And what we mean by that is that it includes the cost of not only the initial construction, but also its operations and maintenance. And let's not forget about the training. Training is many times overlooked and is so very, very important to sustain a facility. All of these costs need to be considered during the planning portion of a program. In general, we have seen that operations, maintenance, and training should be budgeted at 3 to 5% of the initial capital spent for any improvement. Secondly, we also need to consider the facility's ability and willingness to pay for its operations, maintenance, and training when selecting an appropriate technical solution. For example, if the facility cannot afford to pay for the diesel to power a generator that will run an electric water pump, then a hand pump is probably the more appropriate technology that we all should consider. So doing the math, which us engineers love to do, if you have a countrywide program of 2,000 healthcare facilities that cost $100 million, you should be expecting an annual operations, maintenance, and training budget to support those improvements of $5 million each and every year. If these improvements cannot be sustained, another solution should be investigated during the planning phase. A few more points to improve sustainability. First, although it may be tempting to use lower cost items for things like sinks, faucets, and toilets, the cheaper solution tends to present more maintenance problems down the road. We suggest bush-proofing the facilities using resilient, high-quality items. For example, the wall-mounted sink on the right is fine for a home, but for a healthcare facility, a floor-mounted cabinet sink will withstand the demands put upon it much better. In general, it may be better to do 8 facilities resiliently instead of 10 facilities with low-quality items that will require frequent maintenance. Next, the supply chain and parts are very important. By selecting the same items for all facilities that you're responsible for from the same manufacturer and the same model for such things as pumps and sinks, faucets and toilets, it simplifies the training and tools needed to do these repairs. Simple things like a water pump foot valve seal, as seen in the lower left, can become major barriers when you don't have access to the parts or tools that are needed to do these repairs. Stocking different parts and tools for different types of fixtures or pumps has been shown to be a major barrier to sustainability of a program. Also, we need to remind ourselves that staff do turn over and retraining will be necessary. Having a single training manual for maintenance is far superior than having multiple manuals that require multiple sets of tools and parts. My last 2 points on sustainability. Number 1, roles and responsibilities of staff should be done in writing. Details really matter. We have had good luck with checklists, and you may want to consider them. But the point is that staff and managers do change, and having roles and responsibilities documented will help transitions happen smoothly. Second, the sustainable funding for operations, maintenance, and training needs to be identified before you begin your work. If the sustainable funding cannot be worked out before the project is built, we have found that it is unlikely that it will be addressed after the construction. This leads to projects falling into what I call the wash death spiral. The wash death spiral is where funding is insufficient to do proper maintenance, which in turn leads to lower service levels and then attracts less funding until the system finally collapses and fails. Now moving on to waste. Healthcare facilities need to recognize that they are a waste generator and accept that responsibility to make sure that it is disposed of properly. Waste is not someone else's problem. It is our problem as a healthcare facility, and we need to accept that responsibility. Simply ensuring that waste is disposed of at the fence or property line is not enough. Two common observations that I've seen. One, wastewater that is connected to a municipal sewer, but the sewer has no wastewater treatment before it is dumped into a river or drainage way. And secondly, solid waste that is collected nicely into separate colored bins, but then all the bins are simply dumped into the same garbage truck or landfill. We need to do better. We need to accept that responsibility of making sure final disposal of waste is done properly. Now moving on to assessment observations. I think that most assessments teams do a great job of assessing the healthcare facility itself, but many fail to recognize the importance of the healthcare facility setting in the community. We need to make sure our assessments look beyond the fence, beyond the property line of the healthcare facility, and consider the communities in which they reside. For example, do the community residents have access to clean water? If they do not, how will they feel about the healthcare facility getting clean water before they do? This is especially important for a regional healthcare facility that may serve multiple communities. Now, I'm not saying that such a facility should not get clean water. No, that's not what I'm saying at all. What I am saying is that it may take some discussions and consensus buildings, some meetings, to make sure that the support for the healthcare facility is not undermined. Also, the financial context of the healthcare facility needs to be considered. We need to recognize that healthcare facilities are different than schools and homes. People generally expect to pay for household services such as electricity and sometimes water. But what are their expectations for shared services such as a district health facility? Understanding these expectations is important to gain the community's support for the facility and its long-term sustainability. Another common assessment mistake that we see is that people tend to jump to solutions without a proper technical assessment. And I realize that many times this is driven by donors and donors' schedules as they request projects to be submitted. But for example, I frequently hear that a healthcare facility needs a new well, and I'm asked to help them find the proper location to drill that new borehole. But upon my arrival, I've found a perfectly good borehole that is tapped into a virtual swimming pool of clean water. The problem is not a broken pump or a pump that is not set at the correct depth, not that a new borehole is necessary. On one program in Ethiopia, I was asked to visit 52 sites and spot 52 new wells, only to find out that we were able to repair 50 of the wells and only needed to drill 2 new ones. The point is that a technical assessment early can save both time and money. Any of you that know me know that I am passionate about wastewater treatment at healthcare facilities. When I say wastewater, I am most concerned about what engineers call black water, or the water that leaves a toilet. This important waste is a common oversight on many assessment forms, so you may need to add an appendix to your typical assessment procedure and make sure that the expertise is on your team to assess them. A common mistake that I've seen is when latrines are converted to flush toilets when the facility finally gets piped water. If the toilet water is not properly treated, it can violate one of the most basic principles of do no harm. Feces that are now hydraulically mobilized by water are so much more dangerous than when they were contained in a latrine. For example, the photo shows a soak-away pit that no longer soaks away. The sewage is coming to the surface. The healthcare facility has dug a trench to drain the sewage off to a nearby ditch that dumps it into the nearby river, which people use for drinking and bathing. In essence, this facility is recycling pathogens into new patients. This is a situation I've seen far too many times. Finally, just a word of caution that wastewater from a healthcare facility many times needs to be treated differently than wastewater from a school or a home. The wastewater from a healthcare facility can contain high concentrations of cleaning products that can contribute to the difficulty of proper treatment. Also, wastewater from a healthcare facility contains a high concentration of pathogens that are so critical to be removed. A proper assessment should determine the wastewater treatment that is necessary for your facilities. I wanted to share with you one of my personal experiences as I close. One time, I was asked by a district hospital to perform a study to prove that the facility was not the cause of a typhoid outbreak. This was an allegation that some people in the community were making, and they wanted to clear their name. I visited the site and did a dye test at their soak-away pit, and unfortunately, it showed that the hospital waste was discharging within minutes directly into a stream that provides drinking water to so many communities downstream. The look on that hospital director's face is something I never want to see again, as I had to tell him that his facility was indeed contributing to the epidemic. You need to understand that this man, who has dedicated his entire life to the health care of his community, was absolutely devastated. When he learned that his facility was contributing to the spread of the outbreak, he physically collapsed. Finally, my wife reminds me each and every day that yes, engineers are different, but we can offer an important perspective to many assessment teams. And I would ask that you consider having an engineer on your future assessment teams that you assemble. You see, professional engineers, like medical professionals, take an oath that is very similar. We have common goals. As engineers, protect the health, safety, and welfare of the public. So helping healthcare facilities succeed is something that we are really passionate about and excited to work with you on. So with that, here's my contact information. Thank you so much for listening today, and I'll turn it back over to our moderator for questions.
Great. Thank you so much, Mike. This was an excellent presentation, and you've raised a number of important issues, especially around the wastewater treatment, which I'm sure there'll be lots of questions and comments about. Again, thank you so very much. We will turn it over now to Kith Rathamony to give comments. Moni?
Hello, John. Thanks for this opportunity, and thanks, Mike, for your great presentation today. And hello, everyone in the panelists and the attendees.
Yes, we can hear you.
Yes. Okay. You hear me? Okay.
Yes, we can hear you.
Okay. So it's again, that is a great presentation and highlight a lot of issues at a health center that can contribute, like working to, especially to community. The one point that interests me so much is about the clean water at healthcare facility. It's really good if, for example, like the recognition of how how reliable of your healthcare facility to the surrounding community, as well as to the like other community away from the healthcare facility, That is one thing it happened in Cambodia. So it's really good if say like look over the fence, what whether the household or a community right behind or nearby the healthcare facility, whether they have access to clean water, and how do healthcare facility, whether the healthcare facility has access to clean water. So in Cambodia, let me speak like in a small scope in Cambodia in terms of clean water and healthcare facility. In the past year, it has been a really like that image. I mean, mm, the surrounding community, they won't feel good enough to go to the public healthcare facility where one is the wastewater trash disposal, and also the water, the clean water that they use in the healthcare facility, it's not really reliable. Give you an example. For example, like indeed the healthcare facility, they have clean water, but the way that they distribute and the campus, the environment that the healthcare facility they manage the waste disposal, or how to control, how to manage the sewage, like the disposal of wastewater, that is not technically right, where people can see, where people can smell, like like it comes to the mind immediately, like how how can they can provide a good service, or the service is safe enough to the patient that they come uh, for like checkup or medical treatment, or like the service from the hospital or healthcare facility. So it's in my job, like my job as a representative of Splash International Cambodia. I work mostly with the public school, and like the second uh, platform is healthcare facility. So most of the case, people, I mean community people, even the people who get the service from the healthcare facility, they have a lot of complaint about the hygiene, the quality of, of the service, and that is seen by the opinion, like they can't trust their service. Even when they see um, uh, like not a very clean campus, or waste disposal is not appropriate, not standard, and then they feel like they don't want to use the service at the facility. So that is a big problem in the healthcare system in Cambodia.
Great. Moni, thank you so much for your comments. And again, tying it back to what Mike was talking about in terms of looking beyond the fence and bringing in that community perspective on how at least safe water and other wash elements are looked at and viewed from the community perspective. So thank you so much for your comments. We are now going to open up, and I see there's some activity in the chat box. Again, if you have a question you'd like to raise, we're going to open the discussion section up. As a reminder to you all, again, you can put in a question in the chat box. Please select all panelists and all attendees so that we all can see your question or comment. And again, if you'd like to raise your hand and speak, please click the raise your hand button and leave it up until we call on you. And then we will unmute you, so you don't have to worry about searching for the mute button. We will do that from here. So just to get started, I do have a question for Mike. Again, from your presentation, you mentioned that the healthcare facility setting is quite different than providing water or wash services in the households or communities. Could you speak a little bit more about how healthcare facilities differ from other settings? For example, does the transient population impact the work that you do?
Yeah, it's an excellent question. From an engineering perspective, we see several key differences. Certainly, as you mentioned, the transient population can certainly change the water use patterns on a seasonal basis. So we may see people using much more water during certain parts of the year, especially if these are pastoralists that come through the area compared to other parts of the year. So it's really important to pay some attention to those seasonal peaks and how they affect the water usage. Also, the daily water usage is different at a healthcare facility than it is at a school or residence. And when I say daily, this would be the peak demands. You know, so many of us around the world, the first thing we do in the morning is we use water. So those peak demands are usually at 6 to 8 o'clock in the morning, or maybe even earlier. Whereas at a healthcare facility, usually those demands don't peak until late morning. So those are another thing that is critical. The cleaning patterns are much different at healthcare facilities, we found, compared to schools. So, for example, many times the cleaning is done in the evening or at night, and that provides a high concentration of cleaning products that are going down the drain that needs to be considered. And then last but not least, just as was pointed out, the risk element of water at a healthcare facility needs to be considered, in the sense that if the water runs out at a healthcare facility, the impact is much higher than, for example, at a school. So this drives us to use larger storage facilities to store more water so that we lower that risk element of water not being available, and look for redundant methods, plan B, if you will, so that that reliable stream of water can be at that healthcare facility when it's so sorely needed.
Great. Thank you so much, Mike, for your response. We do have a hand raise from Kevin Keeter. Kevin, can you hear us?
I can. Can you hear me?
Yes, we can. Please go ahead.
Okay. Thank you very much, Michael. It was an excellent presentation. I'm on staff with Engineering Ministries International, and our work is very similar to yours. It was great to hear many similar thoughts and observations to the work that we do in healthcare facilities in the developing world. I was just two quick questions for you. I think I'll pose them at the same time because they're not terribly difficult. I loved what you said about the operations and maintenance prioritization and the budget associated with maintaining. And I was curious when you mentioned the 3 to 5%, if that is in the context of basically a wash dedicated project, or if that might be in the context of, say, a new or an expansion of an overall healthcare facility that involves architecture and electrical and new facility itself. So that was the first question. The second question is, one thing that we've noticed on the training side of things is that in the last year or two, we've started implementing more involvement in the training process, and we've noticed this trend in training towards what's called orality, basically meaning that in a lot of the places that we work, the basic learning transform or pathway is through verbal and not through texts and written things such as they are here in the US. And so we've been trying to embrace new methods to train with imagery and story and things like that. And I was curious if that's something that you guys have seen as well.
Yeah, two great questions. Thank you so much. Regarding the 3 to 5%, that's the number that we've generally used for wash interventions as compared to, let's say, an overall architectural intervention. And of course, that can vary a bit based upon what the costs of energy is, if you're using a hand pump or not, if you're on a shared system with a municipality versus your own system. But that's a guideline that we've found that works pretty well as at least a starting point. And then your second point about training, you are so correct that written manuals work very well in the Western world, and they work very poorly generally in other parts of the planet. And so I love your idea of orality. The other thing that we have found that's worked really well for us is actually having a physical model. And so if we can have a physical model that is either at one location where we can consistently do the training of the plumbers on how to do the repairs, or even have it be such that it can be picked up and transported in the back of a pickup truck so that we can move it from place to place, like a sink or a toilet or even a simple pump. Those work really, really well. I mean, the plumbers are people who like to work with their hands. And so when you can have a physical model there that they can touch and feel and actually work with, it seems like that training is much more effective. But thank you for those questions.
Thank you.
Great, thank you so much. We do have another question from Joe from Global Water 2020. And the question is, what can an engineer do to address WASH-related behaviors in healthcare facilities? I think that's to both or either speakers.
Joe, so good to hear from you. Thanks for the question. You know, I think sometimes from my perspective as an engineer who comes in with a technical outlook on the intervention, the first thing is I need to respect that the staff and the operators of those facilities are the ones that are on the front ground. And so spending enough time to listen to them and support them as in their struggles to try to get WASH as part of a cultural change within the facility and within the community is important. It's pretty difficult for us to influence that on a shorter term intervention of a couple of months for an individual project. But the one thing that I have found to be pretty effective is to just share stories about what other people have done and how they've succeeded, because it's really important for people to understand that change can happen. Sometimes we get frustrated and we lose hope that maybe change will be able to happen and people will be changing their WASH perspective. But it does occur, and I think people are encouraged when they hear about success stories.
Great, thank you, Mike.
Lindsay here. I just want to follow up on that note, Mike. One of the things that I think is really interesting, having been to a number of facilities, is oftentimes, not always the whole facility, but certain wards may not have originally been intended to treat patients. They might be offices that have been turned into wards as the facility expanded to care for more patients. And so you can see within the infrastructure, particularly when it comes around sinks and hand washing behavior, how the setup is not conducive to encouraging regular hand washing. So I've been to a number of facilities where the sink is located in an inconvenient location for considering a healthcare worker needs to be washing their hands very frequently to care for the patients. They might have to go down the hall around the corner, and how that is inhibiting behaviors. So I think keeping in mind the location and the proximity to healthcare workers, as well as the number of sinks, there is data coming from Johns Hopkins on sink to patient or sink to healthcare provider ratio that they collected through a PMA 2020 study. And one of the numbers is like 90 healthcare workers to one sink, which you can imagine is just completely outrageous for practicing regular hand hygiene and putting patients in danger, as well as healthcare workers in danger. So thinking about proximity and number of sinks can definitely improve the behaviors within the facility.
Great, thank you so much, Lindsay. We have another question from Douglas Nelson, and this is from Mike. Which categories of pathogens are most critical for wastewater treatment facilities at healthcare facilities?
Yeah, thank you again for the question, Doug. The The ones that trouble me the most are the ones that are particularly resistant to chlorination, because chlorination is one of the most common forms of disinfection that we would use. So Cryptosporidium, for example, is highly resistant to chlorination. And because of that, it really drives us, when we look at particularly wastewater treatment, to consider a multi-level defense or treatment for facilities. A common approach would maybe use chlorination in conjunction with UV treatment that would give us 2 layers of protection against pathogens. One pathogen may be resistant to one type of treatment, but typically not to both. But that would be one thing that I would suggest we keep an eye on.
Great, thank you so much, Mike. We have a hand raise from Morris Tenga. Morris, can you hear us? Morris?
Yes. Thank you very much for giving me a chance to ask and also probably make some comments. I'm sure I've already introduced myself. I'm Morris from Malawi. I'm working with the Management Sciences for Health. And one of the WASH interventions that we're doing is the WASH in health facilities. In the first place, I should appreciate the presenter for the very good presentation. And here in Malawi, we're also doing something related to what is being presented. Now, in his presentation, there's a point about ownership of the WASH, ownership of the facilities themselves, and also even activities taking place there, including waste management. In the presentation, I heard much about like ownership was more leaning towards to the person who is like generating the waste, and also probably the healthcare worker, and probably maybe the government or the owner of the facility itself. Now, I wanted to actually also learn from you with regards to like this possibility of a client when he or she visits the facility. My thinking was that also even the clients, when they visit the facility, they have some sort of a responsibility to making sure that the healthcare facility is clean, and also even whatever waste generated, it has to be well managed. I want to actually learn from your side, because one of the challenges that we actually face here is that in most of the government health facilities where we're working, you find that we don't have enough cleaners to support cleaning in these areas. Sometimes also you find that for the DHO to actually probably quickly come in and repair some of the gaps existing in the health facility, it becomes hard because it needs some funds. So sometimes what we do, we actually also engage the community, the people who actually come and seek health care from this particular health facility. So we engage them to even come in and provide support in kind. So it could be maybe the health facility do not have a refuse pit. So probably the community through local chiefs mobilize people to come and dig a pit so that they can throw refuse in that one. So I'm not sure whether we are in line with the concept that we are learning right now. What I wanted mainly is to actually hear from your experience how others are handling such kind of situations. And my second comment is on the training. In terms of training, I think one of the requirement is that even cleaners, they are supposed to be trained in terms of how they can handle waste, healthcare waste. I'm wondering if we have a standardized training manual, because when it comes to waste management, like you talk of hazardous waste, whereby we separate infectious, non-infectious, the protocol should be probably somehow the same globally. So I'm wondering if we have a training manual that can actually help us to improve our interventions. Thank you.
Thank you so much for some great questions. And I'm going to also ask maybe Lindsay to add in some of her perspective. But particularly under the client ownership, it's certainly important that the community accepts and supports the healthcare facility and recognizes it as a community asset. And I think the more that you can get the community to engage in that process, like as you gave the example of digging a pit that's going to be used for disposal and maybe assisting with some of the maintenance, those are all very positive things. But at the end of the day, I truly believe that the operations of that healthcare facility needs to be owned by the operator of the healthcare facility itself. So that could be the government or some other institution. I don't think it's a sustainable solution to ask the community to provide the operations and maintenance for a healthcare facility by its own. For example, paying for the doctors and nurses and other staff that would be there. The reason I say that is that it may work okay for a few years, but my observation is over time, those communities get stressed for outside reasons. This could be a drought, a poor crop harvest, or some other mechanism. And once that occurs, it becomes extremely difficult to maintain that support during those lean times. And once a healthcare facility has failed, it no longer has the support, it becomes extremely hard to get it restarted again, especially with a solely community-based support network. So I'm a strong believer that the owner of the facility, be it the government or outside institute, needs to bear the lion's share of supporting those facilities. And then under the second question, which is a great one on cleaning, the cleaning training in the manual, I know that several countries have developed some pretty good manuals. I'm sure Lindsay's got some great examples. I will just say that you would think that this would be a universally accepted process, but it's not. For example, I know that there's currently a pretty strong debate about on-site disposal of solid waste versus transportation of medical waste to shared facilities. And I think each country in each region is likely to have a different solution that fits their context. And I think that that's fully appropriate. I don't know, Lindsay, do you have anything else you'd like to add?
So in addition to resources and guidelines, there is an organization which has since closed, Soapbox Collaborative, that put together Teach Clean, which is about cleaning of healthcare facilities training. And it's there is specific focus on healthcare waste management. I'm happy to share that resource. We also did a webinar on this back in March. I believe it's webinar number 7. So we can share the resources for that. There are guidelines, as Mike said, both international and country specific. And most countries have, in addition to an infection prevention and control guidelines, they have a separate waste management guideline. There isn't always a training component to it. But those recommendations of how waste should be controlled are in there. So I can share those with you.
Great. Thank you so much, Mike and Lindsay, for responding to the last question. We do have a new question from Kevin Hengen, and he's asking, how can NGOs find the engineering technical assistance that they need, both local or international?
Yeah, I will take the first crack at that response. The first thing that I would encourage everyone to do is look locally instead of internationally for support. I think you'll be surprised at the level of expertise that is in your own backyard within your country to assist you with things like water supply, wastewater management, and solid waste management. It may not be out in the rural areas. It may be more in the capital or the more urban areas, but that expertise generally does exist. And most countries do have an engineering association now, which is a good place to start if you're looking for some technical expertise. If that gets exhausted, then I think there are organizations like Engineers Without Borders and Engineering Ministries International that would be able to provide some training and help build that capacity in the area that you're working in. I don't know, Lindsay, do you have any other suggestions?
I would actually ask Moni, who has been on the ground doing this more extensively than I have. Moni, do you have thoughts on how you bring engineers on board, particularly local engineers?
Yes, thank you. We do. I mean to select the right partner, we have in Cambodia in particular, we have an NGO directory and also like NGO network. So we normally learn we learn different like a skill set that they can contribute to another NGO that they can partner with. So there is a contact. In Cambodia we have an organization called CCC. So they have like a long list of NGO that they have different professions that they can support in different sectors. So in terms of education, in terms of waste management, in terms of different things. So it is not difficult to get the right partner to support your work in a particular country like Cambodia.
Okay, great. Thank you so much, Moni. Let's see if we have any other questions.
I have one question here coming from Global Water 2020, Joanne. Do you mind if I read it out?
Please go ahead.
Question here from Joe is, what is the biggest challenge, Mike, with your 5-year sustainability plan?
Yeah, thanks, Joe. I think what Joe's referring to is many of our projects that we do where we are doing development type work is we make a 5-year commitment to the communities to do those projects. These are typically through our chapters. And the biggest challenge with those programs is that we've learned that the exit strategy really needs to be identified on day one so that all of the stakeholders understand how Engineers Without Borders will be helping the community with their infrastructure need and the capacity building, but also how we'll be walking with them during these 5 years, but then ultimately fading away so that they're going to be able to sustain the project themselves moving forward. I think a lot of our interventions with the Engineering Service Corps, where we come in and work more like a consulting engineer, Joe, that you would be familiar with, is a little bit different approach where we truly are working on solving a technical problem for a client, in this case, a healthcare facility, and then the the key there is to be able to have ongoing interventions with those facilities to make sure that the sustainability part is truly being addressed. So I'd give you an example of many times one of the things that we work with is on the energy front for healthcare facilities, either looking at what electrical power is necessary or repairing generators or figuring out backup or alternate power sources. And those are typically easy to install once the intervention has been identified, but after a few months, they become a little bit more difficult to maintain. So that follow-up, continued relationship with that organization to make sure that their sustainability concerns and repairs and maintenance are followed up on either in person or over the phone or other communication is so very critical. Great question, though. Thanks, Joe.
Thank you so much, Mike. We have time for one other hand raised from Christine Moe, the director of the Center for Global Safe Wash at Emory. Christine, can you hear us?
Yes.
All right, go ahead.
Thank you both, Mike and Moni, for these excellent presentations. My question is about designs. And Mike, I was interested in your comment about how a wall-mounted sink is less durable than a floor-mounted sink. And I wonder if you have other design recommendations that are more robust and better suited for the needs of healthcare facilities, or if there are resources, websites or manuals that have recommendations on designs specifically for healthcare facilities in low-income settings.
Yeah, that's a great question, Christine. In general, what we do is we look at what we would call industrial specifications and materials compared to residential. So these typically are valves and fixtures that are designed for various types of facilities. You know, schools are another good place to look at in your country that are pretty hard. You know, kids are pretty hard on everything, right? Including wash facilities. And so they're a good place to look at for what their solutions are. Another place that I've used as a good example is military facilities, because again, soldiers are typically pretty tough on wash facilities, and they're a good place to see what resilient solutions can be used in that local context. Of course, as much as possible, we want to use materials and tools that are locally available. We certainly could say that use this particular faucet or this valve that's provided in Italy, but it may not be, the supply chain may not be readily available in that local context. And so we need to be very careful and concerned about that we want the facilities to be very resilient, but we also want to make sure that supply chain is available. So I usually spend some time looking at what is working well at the local school and local military facilities, and then use that as a good indicator on what are the types of materials that can be installed that are going to perform well.
Great. Thank you so much, Christine, for the question, and Mike for your response. We've come to the end of our webinar for today. Again, I just want to thank our speakers, Mike Paddock from Engineers Without Borders and Kith Rathamony from Splash International. Thank you so very much for excellent presentations and discussion. I will say, just before I hand it over to Cassandra, for those of you who may have been a bit late today, I did want to make sure that you're aware that this next month, August, will be our last monthly webinar under the Washington Healthcare Facilities Initiative. Starting in September and going further, we'll be changing the format of how we present webinars. They will be more periodic. They will come from issues within the community of practice that are important for the improvement of Washington healthcare facilities, but they will no longer be monthly. So just please keep an eye out. We will hold our listserv still and send out important updates and announcements, and of course, any advertisements for upcoming webinars, as well as just sending other resources that we think will be important for the community. We will continue to post everything that we do on our website at wnhcfaction.org, and that will do it. So we will see you next month as our last monthly webinar, and now I'll pass it on to Cassandra.
Thank you, everyone, for participating in this month's webinar, and thank you again to Michael Paddock and Kith Rathamony for your wonderful presentations and comments. We will leave the chat box open for a few more minutes, so please feel free to post any additional questions you may have. Today's recording, slides, and a summary document will be available within the next 2 weeks at wnhcfaction.org. These will include an overview of the session, any responses to unanswered chat box questions, recommendations for actions, as well as any resources shared by the panelists. We hope you can join us for next month's webinar about the quality of care in WASH. Thank you so much for your participation today.